All right, everybody, this is Lectures from the ICU, episode number 2. We're going to talk about sepsis today. Um, if there's noise in the background, it's because we're live on shift in the ICU. So sepsis, the definition of sepsis depends on the insurance company. And the reason, I'm 100% serious. The reason because there's two definitions of sepsis. There's one called sepsis 2. Okay, and that's the old definition, and CMS, Medicare, still follows the old definition of sepsis. And what the old definition of sepsis, the one that we all grew up on, was you have SIRS, which is the systemic inflammatory response syndrome. So that's like fever, high white count, low temperature, low white count, tachycardia, tachypnea. Um, That's SIRS, the systemic inflammatory response syndrome. And then if you have an infection, either known or suspected, right, then that overlap is sepsis. So for example, technically, if don't do this, but you could call in and say, hey, I have a fever of 101, my heart rate's 110, and I think I have a UTI, so I'm septic, so I'm calling off. And according to sepsis 2, you'd be correct. Because so that's, they call that sepsis. The problem with that definition is SIRS is very nonspecific, right? So you can get SIRS after trauma, you can get SIRS after watching a scary movie, you can get SIRS after going to a haunted house, you can get SIRS after pancreatitis, and there's a lot of things that are not infectious that can give you that can give you SIRS, right? That's the problem with sepsis 2. So somebody that comes in from a nursing home, for example, and they're tachycardic and they're febrile and they have a UTI, I mean, they're not septic in what we think in the ICU of sepsis. You know what I mean? Then in 2016, I believe, they did all this research on thousands of patients, and they came up with what they call sepsis 3. And sepsis 3 is organ dysfunction as a consequence of a dysregulated host response to infection. That's the definition. Okay? And all of us in critical care are like, yeah, but if you think about it, that's really what sepsis is. It's organ failure because of the body's response to infection. So you have somebody that comes in with renal failure, altered mental status, they're hypotensive because they have a pneumonia, like pneumococcal pneumonia. That's sepsis, right? Okay, that's life threatening. Having a fever and tachycardia with a UTI, and you're walking in the ICU, you're walking into the ER. That's not life threatening organ dysfunction. But when you're hypotensive, you're in shock, you're renal failure, you have liver failure because of a pneumonia or because of a UTI. Okay, that's sepsis. So the way they quantified that is by the SOFA score, the sepsis related organ failure assessment. And there are 6 things with that score. So it's oxygenation as measured by the PF ratio, the PF ratio or the PO2. You have platelet count. You have bilirubin. You have blood pressure, hemodynamics. You have mental status measured by the Glasgow Coma Scale, and there's one more. So oxygenation, platelet count, bilirubin, blood pressure, Glasgow Coma Scale, and renal function, serum creatinine. I pray that everyone's SOFA score here is 0. Okay, so depending on how bad each your organ failure is, you get a point. So if your creatinine's 4, you get, I think, like 3 points. And they're online. They're all the SOFA calculators. So anybody with an infection and a SOFA score of 2 or greater, that's sepsis. Okay, and the way they picked SOFA is because you can pick up, hopefully, sepsis in the hospital. So somebody who already comes in with a creatinine of 3, right, and then goes to creatinine of 6, and now the liver enzymes are going up, and they're a little bit more lethargic, and they're more hypotensive, they might be becoming septic, and in the hospital, it's very hard to detect sepsis a lot of times, right? So that's why they say, okay, if their baseline SOFA score was 3, now it's 8, and they're having a fever, oh, maybe they're becoming septic. So they're trying to pick up the sepsis that's in the hospital. Everybody coming from home who is otherwise healthy, yeah, if their creatinine is 2, that's a SOFA score of 2, and they have they have an infection, then they're technically septic, right? So really the definition, so the commercial insurance companies love sepsis 3 because they can go back and deny all the charts who have a diagnosis with sepsis 2. And they're like, well, that's not the evidence-based practice of sepsis, so we're going to deny this claim, and you owe us $5,000 because we overpaid that bill, right? But the problem is Medicare holds me to sepsis 2. I'm held to account for sepsis 2, but the insurance company is saying, no, it's sepsis 3. And the insurance company is technically correct, right? This is the most recent evidence-based definition of sepsis. So let me stop there. Any questions about that? So, but in like as people in the ICU, you understand what they're trying to come from. That really sepsis is somebody that's trying to die from an infection, right? The body's reaction is trying to kill them because of the infection. That makes sense. It's not really fever and tachycardia, or they're febrile and a little bit tachypnic, and they have a UTI, or they have a little bit of a cold. Like literally, if you have the flu and fever and tachycardia, that's technically sepsis, but that's not life-threatening. You know what I mean? So those are the definitions. The principles of treatment are the same. Whether you have sepsis 1, sepsis 2, the principles of treatment are exactly the same, right? And that's X-ray. I'll look at it when PACS is coming. We're almost done. So number 1 principle of treatment is a high index of suspicion. Okay, we got to be thinking about sepsis all the time. So people don't come into the ER saying, I'm septic. They come to the ER saying, I'm tired, I'm nauseous, I'm weak, I'm dizzy, I have back pain. I saw a patient who actually died from septic shock. She came in with rapid AFib, and she had MDS. She was immunocompromised. She had an underlying infection. Everyone was treating the rapid AFib while the infection was brewing. She came to us too late. She had multi-organ failure and she passed away. So people, you gotta always be thinking about sepsis because it can look like a million different things. Okay, so you have to have a high index of suspicion. Number 2, prompt antibiotics. If you're slow, people die. If you're wrong, people die. So broad spectrum antibiotics as soon as you suspect it. Within an hour or less, even better. And they showed that the longer you wait to give broad spectrum antibiotic therapy, the higher the mortality. And if we're wrong in the beginning, the higher the mortality. So you really got to be right and fast with antibiotics, right? And you can start broad, and then when you get culture, then narrow. Or if you don't get culture, you don't have MRSA or whatever, then you tailor it. But we got to hit them hard in the beginning. Okay. Here's number 3, Hasselbolus. Aggressive. This is me, Hasselbolus. Aggressive fluid resuscitation is my belief. Now, there's been a big debate about we give too much fluids for antibiotics, for sepsis, and the restrictive fluid is better. And all these people, these believers in the restrictive fluid theory, right, have done randomized trial after randomized trial after randomized trial, and every single one of them did not show that aggressive fluid resuscitation was harmful. They were the same. So I am in the aggressive camp. 30 ml per kilo minimum. And if they continue to be fluid responsive, I continue to give them fluid. Okay? It's not forever. I'm not just giving 100 liters of fluid. No, there is danger to giving too much fluid, right? But if they are, a lot of times the COVID patients, they'd come in super dehydrated, right? And we want to keep them dry, but not at the expense of their kidney function. If they're dehydrated, tank them up. Once they stop responding to fluids, then stop, right? And if they're still hypotensive as we're resuscitating, start vasopressors right away. We shouldn't wait for them to continue to have them be hypotensive. No, but we should do them simultaneously. But if someone comes in, they're sick, they're not eating, they've been throwing up, or they're in diarrhea, and they don't feel well, they have no appetite, and then we give them A cup of coffee, the 250 cc bolus is literally a cup of coffee. Is literally an 8-ounce cup of coffee. Not only that, we give it to them over an hour. So we're not only we're giving it someone who's so super sick, they're sitting. Mm, 8-ounce cup of coffee. No, no, no. Give them a liter, 2, 3, until 30 cc per kilo. And if they're 100 kilos, that's 3 liters. If they're 200 kilos, that's 6 liters. If they're 300 kilos, that's 9 liters. Yeah, 9 liters. If you have to start vasopressors, do so. But I'm in the aggressive camp, and multiple studies have vindicated Dr. Hassabolis, and there's no harm in giving aggressive. There's a limit. You can't just keep giving saline forever or LR forever. But I don't believe in under resuscitating in the very beginning, right? And then source control. That's the other crucial. If they have an abscess, you got to drain the abscess. If they have an infected line, you got to pull the line out. If they have an infected pacemaker lead, you got to pull the lead out. Because we could be giving fluids, antibiotics, and pressors until the cows come home. It doesn't matter if the source is not taken care of. If they have an obstruction, relieve the obstruction. They have an empyema, we have to drain it. If they have an abscess in the belly, you got to drain it. Otherwise, they will never get better. They will not get better. So source control is absolutely critical. It's finding where. A lot of times we don't know the source. Half of the time, at least half of the time, if not more, I don't know where the infection is. Right? We suspect it could be pneumonia, it could be a UTI, maybe it's something. But if they're not getting better, we should search for the source. I think we had a patient with a pacemaker lead infection, and he was sick, fever and pressors and Leukocyte. As soon as you pull the lead out, he magically got better. Yeah, you got to take the source of the infection out. We don't control the source. The patient will never get better. And those are the main principles of sepsis. We've tried everything. We've tried activated protein C. We've tried anti-endotoxin antibodies. We've tried, you name it. We've tried it. Fluids and antibiotics. That's what saves people's lives in sepsis. So we have to always be thinking about it. We have to be very quick in treating it, and then take care of the source if we can find the source. And that's kind of the gist of sepsis. What questions? Do you have any questions? Any concerns?
Where does the Q-SOFA score fit into
the Q? So that's a very good question. So where does the Q-SOFA score? So the Q-SOFA is like a quick SOFA score, and it's mental status, blood pressure, and respiratory rate. So it's like a quick and dirty look to say, okay, could they be becoming septic? That's where they because the SOFA score is like you have to have a PO2, you have to have a serum creatinine, you have to have a Glasgow Coma scale, a bilirubin, a platelet count. So the quick SOFA is like for a rapid response. You could do a quick SOFA score. Someone walks in, they're febrile and they're obtunded and tachypnic and hypotensive. They're like saying, okay, maybe the more elements of the Q-SOFA you have, the higher the mortality. But you're going to know. I think you're going to know that as a rapid response nurse, as a critical care clinician. You walk in and they're lethargic and they're hypotensive and they have a fever. They're probably sepsis. So that's where the Q-SOFA is coming in to try to give you a quick and dirty. That's why it's called the quick SOFA, a quick and dirty assessment to say, oh my God, this patient could be septic. And I argue, and we all argued, a lot of us in their field said, hey, if they are obtunded and hypotensive and tachypnic, we're too late, right? We're way behind the 8-ball. So, but that's where the Q-SOFA comes. Is try to a quick and dirty assessment. Again, because when sepsis is so easily missed, and it's mimicked by a lot of things. It mimics a lot of things. We're trying to raise the awareness so we don't miss septic patients. Because if you miss them, and the organ dysfunction and the cycle starts, it's very hard to control it. Once the pathophysiology has unleashed in the body, it's very difficult to come under control. When you're already behind, a lot of times you can't. And that's how a lot of COVID patients died. They became septic, right? And then everything just spiraled out of control, and there's nothing we could do to stop it. I mean, we did everything we could. They were on antibiotics forever. I mean, I'm not blaming anybody. That's just how it went, but that's what we're trying to do with the new rules is to try to make sure that we're thinking about sepsis all the time so that we don't miss it. Because a lot of times it just mimics other things. So that's where the Quicksilver comes in. Questions? Oh, that's a very good. So that's a good question. What's the purpose or the utility of procalcitonin? It's not very useful for sepsis, right? Procalcitonin can tip you off to a bacterial infection. So if somebody comes in with a procalcitonin of 50, right, which I've seen, and 99 and 15, that kind of tells you there's probably a bacterial infection. Maybe you want to treat with antibiotics, right? But I don't think like a really high procalcitonin is going to tell you, oh, this patient's septic as opposed to a low procalcitonin. It doesn't figure into my thinking. Now, the highest procalcitonins I've seen have been with gram-negative septic shock or gram-negative infection or gram-negative bacteremia, but I don't think procalcitonin is part of that thinking or part of that universe. It was hoped to be a marker of bacterial infection so that we don't treat people without bacterial infection unnecessarily, but I'm not sure it's panned out that way, unfortunately.